Thank you, Ashok Sham sir. Good evening, everybody. Myself, Dr. Avinash, welcomes you all to 11th live PRAC webinar organized by Sanchit Hospital, Pune. Today, we will discuss two blocks, adductor canal block and PENG, that is pericapsular nerve group block. Dr. Mamta Sadare will speak about adductor canal block. Dr. Mamta Sadare, she is a senior consultant anesthesiologist and she is practicing at Sanchit Hospital more than 20 years and conducting anesthesia for joint replacement surgeries. So I now request Dr. Mamta Sadare to begin with her presentation.
Good evening, all. Yeah. Yeah. Please go ahead.
Dr. Sadare, are you ready with your presentation? Yeah.
Hello. I think some network issue somewhere. Okay. Starting.
Good evening, everybody. Thank you, Avinash, for kind introduction. At the outset, I extend my thanks to Divan sir and PRAC team for giving this opportunity. I shall be talking on ultrasound guided adductor canal block. Adductor canal is an aponeurotic tunnel in the middle of thigh, extending from apex of the femoral triangle to the opening in the adductor magnus, the adductor hiatus. Adductor canal block is largely a motor sparing block, anesthetizing the femoral nerve after most of the motor branches to quadriceps have already exited, providing anesthesia and analgesia intraoperatively and postoperatively. One of the earliest work leading to the development of adductor canal block was done by Van der Waal and his associates. In 1993, they did clinical study and established the block's clinical viability utilizing cadavers. They described it as subsartorial approach to the saphenous nerve blockade. Their aim was to describe an alternative to traditional landmark approach to the saphenous nerve block. They established foundation of saphenous nerve block to provide analgesia for surgical knee procedure. Now we shall see the anatomy of the adductor canal block. Femoral nerve passes through the femoral canal to lie beneath the sartorius muscle, entering the aponeurotic intermuscular tunnel in the middle third of medial side of thigh. Adductor canal is bounded anterolaterally by vastus medialis, anteromedially by sartorius, and posteriorly by adductor longus and adductor magnus. The contents of the adductor canal are femoral artery, femoral vein, saphenous nerve, nerve to vastus medialis, and posterior branch of obturator nerve. This is the transverse section of mid-thigh, showing the position of the adductor canal with its contents. Contents of the adductor canal are femoral artery, femoral vein, saphenous nerve, nerve to vastus medialis, and posterior branch of obturator nerve. This picture shows distribution of saphenous nerve with its cutaneous branches. Ultrasound anatomy. The sartorius muscle appears as trapezoid shape beneath the subcutaneous layer of adipose tissue. The sides of the triangular canal are formed by vastus medialis laterally, adductor longus or magnus medially, depending on how proximal or distal the scan is. The saphenous nerve is typically imaged by ultrasound as a small round hyperechoic structure anterolateral to the artery. The femoral vein accompanies the artery and the saphenous nerve in the canal. All structures can be identified at the depth of 2 to 4 centimeter of the USG screen. This is the cadaveric picture of adductor canal block showing its vessels and nerve. Indications of adductor canal block are analgesia for knee surgery in combination with multimodal analgesia, saphenous vein stripping or harvesting, supplementation for medial foot or ankle surgery in combination with sciatic nerve block, rescue analgesia for surgery to the anterior part of the knee, for example, knee arthroscopy, patellar surgery, anterior cruciate ligament, medial cruciate ligament reconstruction surgery, and superficial surgery to the medial side of the leg. Contraindications of adductor canal block are patient's refusal, history of allergy to local anesthetics, infection at the site of injection, coagulopathies, and neurological disorder. Equipment required are monitoring devices, IV access, ultrasound machine with linear transducer with frequency of 8 to 14 megahertz, sterile sleeve and sterile gel, standard nerve block tray, 20 ml syringe filled with local anesthetic, 50 to 100 mm Stimuflex needle, and sterile gloves. Technique of adductor canal block. Position the patient supine with the knee slightly flexed and externally rotated. Position the ultrasound machine so that the operator, insertion site, and ultrasound machine lie in one line. Use a high frequency linear probe. Place the probe transversely at the level of center mid-thigh, visualizing the femur. Slide the probe medially until the femoral artery becomes visible with the boat-shaped sartorius muscle above. Adjust the depth so that the femoral artery in adductor canal lie in the center of the screen. The nerve may be seen anterolateral to the artery, but sometimes may not be easily visualized. This is the video showing the scanning of the adductor canal at the mid-thigh level. Place the probe at the center of the mid-thigh. Move it medially to look for the femoral artery below the sartorius muscle. The nerve is looked anterolateral to the femoral artery. This is the ergonomics of adductor canal block. The introducer, insertion site, and USG machine lying in one line. This picture is showing position of the patient, knee flexed, externally rotated, proposition transversely at the mid-thigh level with marker on the lateral side, and high frequency linear probe is used. Needling. Insert the needle from lateral to medial side using in-plane technique. This can be achieved via a steep angle traversing sartorius or more horizontally by piercing vastus medialis and traveling perpendicular to the ultrasound beam. Once the needle enters the adductor canal, the needle tip should lie immediately lateral or superficial to the femoral artery. Perform an aspiration test, then inject the test dose of local anesthetic. Ensure spread around the nerve. If the nerve is not visible, position the needle tip superficial to the artery and ensure the local anesthetic spread around the artery. If no local anesthetic is seen, consider intravascular injection and stop injecting immediately. Once the correct position has been confirmed, inject the total volume of local anesthetic, aspirating frequently to rule out intravascular injection. This picture is showing the target point in the adductor canal to block the saphenous nerve anterolateral to the femoral artery. This is the video showing adductor canal block is getting inserted in the adductor canal. Injection is being given around the nerve. 15 to 30 ml is being injected. And now is getting prominent with the spread of drug. And vessels are getting displaced due to the spread of local anesthetic. This is the video showing needling of adductor canal at the mid-thigh level. The needle is getting inserted through the sartorius to reach in the adductor canal lateral to artery, and drug is being injected. We can see the now is getting prominent and spread of drug is seen. This is the picture showing position of the needle in the adductor canal. We can see the drug spread in the adductor canal. The vessels may be slightly displaced due to the spread of drug. Why ultrasound is must for adductor canal block? Because ultrasound guidance allows operator to visualize the nerve. It increases the efficacy and safety of the block. This picture shows the three different approaches of adductor canal block. A is the proximal side, just below the apex of femoral triangle, where medial border of adductor longus intersects with medial border of sartorius. B corresponds to the mid adductor canal at the mid-thigh level. C corresponds to the distal end of the adductor canal, where the adductor hiatus lies. This is the ultrasound picture at the proximal end of the adductor canal, where medial border of sartorius intersects with the medial border of adductor longus. Clinical pulse. Always put monitor and start IV line before giving the block. Always keep anesthesia trolley ready. Frequent aspiration is a must to rule out intravascular injection. Never inject when there is resistance. Always see the spread of drug around the artery. If drug spread is not seen, needle tip may be in the vessel. That time, withdraw the needle and then redirect it. Always give test dose and then give the rest of the drug. Proper visualization of the canal is must to avoid intramuscular injection of the drug. If the nerve is not clearly visualized in the canal, inject the drug anterolateral or superficial to the femoral artery in the canal. High volume, more than 30 ml should be avoided to avoid the muscle weakness because distant spread of the drug may occur, causing muscle weakness. Always use in-plane approach because with out-of-plane approach, the tip of the needle may not be properly visualized. Complications: arterial puncture, bleeding, block failure, intravascular injection, infection, and nerve injury. All this can be prevented by taking proper precaution. The drug and doses which are used for adductor canal block are 15 to 30 ml of ropivacaine, 0.1 to 0.375%. Bupivacaine 15 to 30 ml, 0.25 to 0.5%. Adjuvants which we can use for adductor canal block are dexamethasone 2 to 4 milligram, clonidine 15 to 30 microgram, and fentanyl 0.5 to 1 microgram per kg body weight. Continuous adductor canal block is recommended for prolonged analgesia and for early mobilization. Under USG guidance, 18G two-hose needle inserted in adductor canal with in-plane approach at the mid-thigh level. Hydrodissection done with 8 to 10 ml of normal saline. Flexible catheter 19 to 21 G is passed 2 cm beyond the tip of the needle in the adductor canal. Needle is then withdrawn and tunneling is done on the proximal anterior thigh and secured well with adhesive tape. Position of the catheter is always confirmed under ultrasonography. After giving bolus dose, infusion pump started. The recommended dose for continuous adductor canal block is 0.1% ropivacaine 5 to 6 ml per hour and 0.1 to 5% bupivacaine 5 to 6 ml per hour. Catheter should be withdrawn after 48 to 72 hours. This is a picture showing catheterization in the adductor canal for continuous adductor canal block. This is the original research, a cadaveric study for the evaluation of the proximal adductor canal block. The objective of this cadaveric study were to evaluate dye-inject spread and quantify the capturing rates of nerve supplying the articular branches to the knee joint capsule using a proximal adductor canal injection technique. They concluded that proximal adductor canal injection has a consistent tire split pattern capturing the posterior medial branch of nerve to vastus medialis, superior medial genicular nerve, saphenous nerve, and genicular branch of obturator nerve. This may explain why proximal adductor canal injection confers greater analgesic effect than a distal injection, while also preserving quadriceps muscle function. Further clinical investigation is required to confirm the categoric findings. This is a review article from Journal of Clinical Anesthesia by Stott and Thomas in 2016. They studied comparison of adductor canal block and femoral nerve block for patients of knee replacement by using VAS score and quadriceps strength. They found adductor canal block provides equivalent analgesia to femoral nerve block for primary total knee replacement with added advantage of less quadriceps weakness and early ambulation and a trend toward early discharge. The adductor canal block can also be used as a rescue block in patients with moderate to severe pain after minor orthoscopic knee procedures. The ultrasound guided mid-thigh technique using 0.2% ropivacaine or equivalent local anesthetic with 15 to 30 ml volume seems to be the optimal approach. Further research is warranted to delay adductor canal block on time to discharge and the use of single shot versus continuous adductor canal block. A randomized clinical trial by Abdullah and Rebecca was done in 2019. They studied opioid and motor sparing with proximal, mid and distal locations for adductor canal block in anterior cruciate ligament surgery. They found proximal adductor canal injection location decreases opioid consumption and opioid-related side effects without compromising quadriceps strength compared to mid and distal location for adductor canal block in patient undergoing ACL reconstruction surgery. This is the original article from Regional Anesthesia and Acute Pain Journal. The study was done by Bucket and Philip Pang in 2016. They studied the nerves of the adductor canal and the innervation of the knee. And they concluded that combination of both saphenous nerve and nerve to vastus medialis provide substantial innervation to the anteromedial aspect of the knee joint, including the joint capsule and the medial retinaculum. The nerve to vastus medialis plays a major important role, whereas obturator nerve contributed to the subsartorial plexus in small portion. The result of the study suggests that the mid portion of the adductor canal could also be optimal site for local anesthetic administration, proximal enough to consistently block the saphenous nerve and nerve to vastus medially, while minimizing the spread to the popliteal fossa, and distal enough to avoid significant spread to the femoral triangle. They concluded adductor canal block added to single dose of local infiltration anesthesia offered better analgesia and facilitated ambulation without motor weakness after medial unicondylar knee orthoplasty. Adductor canal block provides equivalent analgesia to femoral nerve block for primary knee surgery with added advantage of maintenance of quadricep strength. It is highly recommended for early ambulation and trained towards early discharge with short hospital stay. Very highly recommended for institute where fast track knee surgeries are being taken. Continuous adductor canal block can easily be given for prolonged analgesia for early ambulation. Thank you.
Hello, Avinash.
Yeah, I can't. Yeah, thank you. Thank you, Dr. Sadre, for that detailed presentation. Now we move to our next lecture by Dr. Bharati Adde. The topic is pericapsular nerve root block, which is used as an anesthesia modality for hip fracture, especially anterior hip replacement surgery. Dr. Bharati Adde, she is a senior anesthesiologist and head of the department at Sancheti Hospital. She has successfully conducted anesthesia for hip and knee replacement surgeries for more than 20 years at Sancheti Hospital. I request Dr. Bharati to start her presentation.
Good evening. Hip fracture is a common orthopedic emergency in the elderly patients with significant morbidity and mortality. Effective analgesia is essential in this mostly high-risk population. PENG block is a novel ultrasound-guided regional anesthesia technique ideal for these patients. The most common regional anesthesia technique used for hip patients are femoral nerve block, fascia iliaca block, 3-in-1 block. The aim is to reduce opioid consumption and thereby reduce opioid-related adverse effects. But these techniques provide only moderate analgesia and the obturator nerve is consistently spared. Moreover, the cephalad spread of the local anesthetic rarely extends beyond L5. PENG block was introduced in 2018 by Giron Narango and Philip Payne. It is actually the pericapsular nerve group block. It's a ultrasound-guided pericapsular infiltration of the hip joint and targets the articular nerves supplying the anterior hip capsule. There has been a renewed interest in the hip innervation studies, as has been discussed in this article published in the same year 2018. Authors have studied the anatomical distribution of the articular nerves of the hip joint, especially the pattern of anterior capsule innervation. As you all know, the dorsal aspect
Hi,
of
Ro.
hip joint
Hi, Kailash.
is supplied by one or more branches of sacral plexus through the nerve to quadratus femoris or superior gluteal nerve or articular nerves directly from the sciatic nerve, whereas the anterior aspect is supplied by the articular branches from femoral nerve, obturator nerve, and accessory obturator nerve. It's an interesting study which enlightened us on the pattern of distribution of the neural components in anterior and posterior part of hip joint. It was found that the density of the mechanoceptus is highest in the superior part of anterior capsule and least in the posterior capsule. So, effectively speaking, posterior capsule is concerned more with proprioceptive component and nociception is the function of the anterior capsule of hip joint. Coming to functional anatomy, there are three important bony landmarks. The anterior superior iliac spine, that is ASIS, anterior inferior iliac spine, that is AIIS, and iliopubic eminence, that is IPE. The anterior capsule of hip joint is located between the anterior inferior iliac spine and the iliopubic eminence. For practical purpose, we can divide the anterior capsule into 4 quadrants. There are 3 main nerves which give articular branches to anterior hip capsule, as you know. If you see this picture, the femoral nerve gives articular branches to all the 4 quadrants. Accessory obturator nerve supplies both the medial quadrants, and the obturator nerve innervates both the inferior quadrants. The articular branches from the femoral nerve leave the main nerve at L4-5, push deep to the psoas muscle and descend between the anterior inferior iliac spine and the iliopubic eminence. The obturator nerve descends in the pelvis medial to the psoas muscle and emerges through the obturator foramen. High branches are given directly from the main obturator nerve within the obturator canal, and the low branches arise either from the anterior or the posterior division. These branches deflect laterally to innervate the anterior medial hip joint capsule and inferior part. The third nerve, the accessory obturator nerve, arises from L2 to L4 ventral rami and descends deep to medial aspect of psoas muscle at L5 level. It crosses the iliopubic eminence close to the iliopubic. It crosses iliopubic ramus close to iliopubic eminence to supply the anterior and medial joint capsule, pectineus, and adductor muscles. So we find that all the articular branches coming from all the 3 nerves are in close proximity to the area between the anterior inferior iliac spine and the iliopubic ramus. And we use these landmarks when we do the PENG block. Here we place the probe, we place the ultrasound transducer to visualize the area between the iliopubic anterior inferior iliac spine and the iliopubic ramus, iliopubic eminence. The usual preparation protocols for any regional anesthesia must be followed for PENG block as well. Linear transducer can be used for slim patients, while Low frequency transducer curvilinear probe should be used if the target structures are deeper than 4 centimeters. It certainly provides a wide field of view to identify all the relevant structures. 80 to 100 millimeter needle is recommended to reach the deep targets. The target for block is the articular nerves lying between the psoas tendon and the ilium. We can clearly identify all these structures in this image. They are ASIs, the anterior inferior iliac spine, the iliopubic eminence. This is the iliopubic notch, iliopsoas notch, femoral artery, femoral nerve. This is psoas tendon. This is the iliacus muscle. This is the psoas muscle, and this part is the psoas tendon. And this is the point where we intend to deposit our drug. The patient is placed in supine position with leg fully extended and slightly externally rotated. We usually mark the ASIs and the inguinal ligament and the femoral crease. There are two techniques of scanning. Let us start with the first technique. Here, the probe is placed over the ASIs in transverse plane. Once the ASIs is identified, the transducer is rotated either anti-clockwise or clockwise, depending on whether it is a left-sided or right-sided block, so as the probe is aligned to the line starting from ASIs, AIIs, iliopubic eminence, and tubercle. In the video, we can identify all the structures. This is AIIs. This is iliopubic eminence. You can see the femoral artery. This is here lies the femoral nerve. This is the iliacus muscle. This is the psoas muscle, and this is the psoas tendon. The second technique has a slightly different sequence. Probe is placed in oblique orientation over the femoral artery so that it is roughly parallel to the iliopubic ramus. We need to identify the femoral artery so that that is the first thing we need to identify in this scan. Then we need to identify the iliopsoas muscle and the femoral nerve. Then we try to visualize the underlying hyperechoic bone. If it is curved, it is the femoral head in hip joint. As we slide the transducer slightly cephalad, the curved part becomes fairly linear, and this is the ilium bone or the iliopubic ramus. Needle trajectory should be carefully planned from lateral to medial in plane so as to place the needle tip in the area over the iliopubic ramus, just lateral to the psoas tendon. Okay, so the drug is deposited lateral to lifting the tendon away from the superior pubic ramus. As you can see, the drug sprayed. This is where your drug should be deposited. This is another video using a linear transducer. You can watch the drug spray. The needle is beautifully placed next to the psoas tendon, and there is a beautiful drug thread between the psoas tendon and the iliopubic ramus. The same thing can be seen with the video, which is by using the curvilinear transducer. Again, the needle is placed lateral to the the psoas tendon, and the drug is deposited between the psoas tendon and the iliopubic ramus. Local anesthetics commonly used are bupivacaine or ropivacaine, with or without epinephrine, or you can add even clonidine. The usual volume advised is 15 to 20 ml. You can see from this diagram that the spread of the 10 ml dose is slightly limited, whereas the spread of the 20 ml dose is extensive and seem to cover all the articular branches right from the branches from the obturator nerve. PENG block is indicated for perioperative analgesia for hip fractures, hip arthroplasties, the DHS or the dynamic hip screw fixation. It is a preferred mode of analgesia for hip arthroscopies. Many people have been using this block for positioning the patient for spinal or epidural incisions. We have been using this block regularly for conservative management of hip fracture patients, and also when the patient is getting investigated and prepared before surgery. The important point to note here is that this PENG block does not cover the surgical incisions. If you see the common incisions, this is the posterior incision, this is the anterior incision, this is the posterior approach to hip surgeries, anterior approach, lateral approach, and this is the incision for the DHS. If you see here, this part is covered by lateral cutaneous nerve of thigh. So in perioperative settings, PENG block needs to be combined with other blocks like lateral femoral cutaneous nerve block or fascia iliaca block. The advantages of PENG block are that it is simple to perform, it is given in supine position, the needle placement is away from vascular structure, it does spare all the motor power, and definitely provides effective analgesia for dynamic hip pain. Recently, PENG block has been explored in other scenarios like pelvic fractures. They used slightly higher volumes from 30 to 40% and found that PENG block has rapid action and may be used as on-arrival block for such pelvic fracture patients or acetabulum fractures as well. There are few reports of quadriceps weakness after PENG block. It is said that the anterior layer of fascia iliaca is quite tough, and if the drug gets deposited over the fascia iliaca, then it can definitely reach the femoral nerve and block it. So it is advised that the needle should be gently rotated when we are trying to pierce the fascia iliaca. Secondly, if the needle position is too medial to the psoas tendon, or if the drug goes intramuscularly, it can reach the femoral nerve and can cause quadriceps weakness. So care should be taken. Another word of question. The pelvic part of the ureter lies on the pelvic wall, where it is in close relation to the obturator nerve. So a more medial placement of the needle or medial to lateral needling technique can cause injury to the ureter. Care should also be taken not to make needle entry too close to the ASIS, so as it can cause injury to the lateral femoral cutaneous nerve that lies near sartorius muscle. Recently, an article is published in Indian Journal of Anesthesia. The authors have discussed about the feasibility of landmark-based pen block. It looks quite interesting, but with the possible problems that we have just discussed, landmark-based pen block seems to be not so safe. When I was thinking how I should summarize this talk, I came across this interesting tweet. It says, it's a pericapsular block. It can be performed supine. It's a low-risk block. It is motor sparing. And though it does not cover the lateral femoral cutaneous nerve area, it does cover femoral and obturator osteotomes. So let us look at the other side. This block is quite fairly new, and there is a lot of questions about how actually the drug spreads in patients to all the nerves. There are no properly designed RCTs or dye studies. There are only few reports where catheter technique for PENG is explored. So though PENG seems to be a great block for hip surgeries, it is still evolving, and there are certain gray areas which needs to be addressed. I'm sure our Dr. Amit Dixit and our very own Sandeep Diwan can throw some light on these issues. Thank you.
Thank you, Dr. Bharti Madam, for that concise presentation. Now we move to our next session, that is panel discussion, which will be chaired by Dr. Amit Dixit, who is a consultant anesthesiologist at Rubyal Clinic, Pune. And as a panelist, we have three consultants from Sancheti Hospital, Dr. Sandeep Diwan, Dr. Nitin Gavi, and Dr. Himanshu Longri. Over to Dr. Amit.
Okay. So it was really nice presentation by Madam, Sadre Madam and Bharti Madam. And it has really dealt in great detail about the anatomy and block dynamics. One or two comments I wish to add. First about the knee part, and second about the hip part. So starting with hip, because PENG block is recently being utilized in various ways. So what I'm trying to highlight, which already Madam has covered, if we look at the anatomy, the hip joint has predominant neural innervation in its anterior aspect, and it is dominated by femoral and obturator component, which is rightly demonstrated. So the analgesia for hip surgery depends on type of surgery. I mean, whether if the hip is remaining in situ at the end of surgery. I mean, if we are doing a DHS, we are doing a bipolar hip, or we are doing a total hip replacement. So these mechanoceptors and all the periosteal component is removed at the end of surgery, then probably whatever these obturator and the femoral articular branches, they may not be very useful. So post-operative pain and pre-operative pain are different when it comes to hip surgery. So pre-operative pain is mainly from the mechanoceptors, the joint, the periosteum. And once the surgery is done, it is the surgical incision and the muscle cutting incision which are more or less responsible. So when we are planning for a hip analgesia, we have to look at the type of surgery. So there are surgeries where there is good amount of muscle cutting, then probably I need those blocks which will block the muscle, the adductor compartment, the quadriceps compartment. So these femoral and obturator nerve blocks, where they are paralyzing the muscle, if the muscle is getting cut, then probably for post-op analgesia we require that. As far as madam has rightly pointed out, the skin infiltration, it can be done by surgeon, or we can do a lateral femoral cutaneous nerve block. So this will affect post-op analgesia. When we think of PENG block, it is, I think, wonderful to have it as a on-arrival block. Now, when we look at different published literature, the important component we have already concluded it is femoral and obturator. So whether we should go for PENG, or some people who are using, who have not been, very well versed with the technique, they may still be using femoral. Absolutely fine. I think you can make the patient sit with the femoral. What we have found is when we are using only femoral for post-op analgesia, patients are comfortable in lying down, but when we ask them to move and roll over, they may feel little bit of pain. So combining it with a subpectineal obturator with femoral is helping in those patients. So this is some brief idea about the hip aspect. So there is no clear-cut recipe. So you have to look at the, what is the type of surgery, how much muscle cutting, where is the skin incision, and at the end of surgery, what is happening to the joint cavity? It is getting completely removed. Are the mechanoceptors, the articular branches, still we really need to block them? So madam has rightly pointed, the conservative hip management, PENG block definitely has a role, because they are densely innervated there. Now coming to knee, we had a fantastic description of adductor canal. How I look upon knee is getting opened with a medial parapatellar osteotomy. It is medial parapatellar osteotomy. There is a iatrogenic fracture at both ends. And at the end of 3 and 6 hours, with early mobilization protocol, we tend to move these two joints. So it produces a lot of pain. I mean, it is one of the most painful surgeries. So what are the important nerves? Definitely the saphenous nerve. And because it is medial parapatellar orthotomy, it is nerve to vastus medialis, which has got a phenomenal role. Many patients do complain of posterior knee pain, where there is a role of the sciatic component, and that is why we do IPAC, or some try to address the sciatic component as well, because 40% of the patients do complain of that sort of pain. So if there is a lot of genuine valgus deformity, it is a relative contraindication for a sciatic block. And if we give a selective sciatic nerve block, sometimes patients as if they are walking on a cotton bed or something, so it causes some sort of numbness over foot. So we are into a era of site specific analgesia, so we tend to block either with IPAC and a adductor canal block. But if adductor canal block we want to utilize fully, then there are group from Thomas Benston and all, where they are using a proximal and a distal adductor canal block, and we can have all the 4 nerves blocked, like the saphenous, the nerve to vastus medialis, and the obturator and the sciatic component. This is how it is. So there is still in this area also, there is no clear-cut recipe. I was looking at few articles. It says that there are almost 137 modalities of treating knee. So it depends on how efficacious you are with your technique, with your block, and you can use combination. Whether really on the day 0, your surgeon wants to make that patient sit and stand and walk, it totally depends. So this was some brief outline. We need to look at osteotome, myotome, on the nerve supply, the incision, and what is the requirement of our patient, our group, and then we have to look upon. So after this brief idea, I wish to ask Bharti madam, what is her opinion in combining PENG? Are you using only PENG, or you are combining it with others? And whether you are using pre-op or post-op, how it is?
Yeah. Amit, that was a real nice comment on both the lectures, I should say. And yes, your question is very relevant. As you know, this PENG block should ideally be used in a pre-operative setting. And even when you are using it as a perioperative block, it needs to be combined with either lateral femoral cutaneous nerve, because it needs to cover the posterior approach of the hip surgeries. In our hospital, we are not using anterior approach to hip surgeries. So we have to cover it with LFCN block, or if you are not comfortable, then you may give a small dose of maybe suprainguinal fascia iliaca block. But again, it's like depositing your drug under the iliopsoas and over the iliopsoas,
Yes.
both the things. And one more I would like going to deposit the drug at a very close surgical site. For it that should identify before surgery. After surgery, when it's not otherwise you may different planes, and you may not have that motor sparing effect also. So this is another thing. And in our hospital, I think I've been doing a lot of PENG blocks for my sort of on arrival for our patients. So many of them, they need to be investigated because they're the elderly patients who need some investigations or optimization. So this block works wonderful for them because, as I said, PENG block gives you a fantastic pain relief that is a dynamic hip pain. The patient can move the joint and still be without any pain. So really it gives a good hope for them that, okay, they are going to get up from bed and walk. So this is basically a pre-operative block, not the post-operative. I will not do the PENG block in the post-op period unless there is real indication. And some patients who are very sick and you cannot operate them, where you want to wait for a day or two and try to mobilize them in a wheelchair also. This is again a situation where what I said as conservative management of hip fractures. You can definitely give them PENG block, make them pain-free, and then try to mobilize them, maybe with wheelchair at least.
Yeah.
And about your comments about knee surgeries, the adductor canal block, so many times you have to supplement the sciatic component either with your IPAC, or your surgeon may be putting the posterior capsular local infiltration, or you may go for a sciatic block, which I think hardly anybody is doing for knee surgeries, because you are always worried about the foot drop, which may temporarily happen, and then your surgeon is worried how quickly he can ambulate the patient. So IPAC needs to be combined with the adductor canal block.
Yes. So what concentration usually you tend to prefer for PENG block, the drug, the concentration, dose, how much volume?
I depending on the weight of the patient, I usually give at least 15 to 20 ml of, if it's a conservative, I will go for 0.5% bupivacaine with clonidine. That's the very good combination, because it will keep the patient pain-free for a long time, and really more than 24 hours so many times. That is what we have seen. So you need to give a good dose. If it's a very tiny patient, 40, 50 kg, then maybe we can just give 10 to 15 ml. But 0.25% bupivacaine or 0.5% bupivacaine, depending on the stature of the patient.
The article which mentioned about the femoral nerve involvement in PENG block, can it be because of the needling, or how the trajectory of the needle, where it tends to go close to the femoral nerve at times?
Yeah, that is the reason I said you have to plan your trajectory when you are doing the PENG block.
Yeah.
It is very important because two main nerves are sitting on top of the fascia iliaca, the lateral femoral cutaneous nerve laterally and femoral nerve medially. So you need to identify at least the femoral nerve and stay away from the ASIs also, so that you avoid the LFCN also. So that is the reason you must plan your trajectory and then insert a needle so as to avoid LFCN as well as femoral nerve, and definitely your needle should land lateral to the psoas tendon, so that it doesn't spread intramuscularly or even doesn't spread to the plane between the psoas and the pectineus, because through that plane also the drug may seep up and block the femoral nerve, and then you lose the motor sparing tendency with this PENG block. That is the advantage. So deposition of the drug in the correct plane is, I think, most important in this block.
Yes. Yeah. Yes, correctly said. And we nowadays, with a lot of publications coming in with some modifications, one of the modification is going 2 centimeter distal and achieving a iliopsoas plane block, which is
Correct.
more
Subpectineal.
yeah. So what is the advantage, or it is more or less the same? What is your opinion? Like, I mean,
I think it is. I mean, if you read the article by Nelson and if you read the article by Laura Giron-Arango, they are probably talking about the same plane with a little
Correct.
difference in the.
Yes.
So it's actually one and the same.
Yes.
Whether you are going sub-psoas or you are going subpectineal or you are going just above the ileum.
Yeah.
It's sort of one and the same. We need to really do the dye studies to check what both these people are saying and whether the drug is going in the same plane.
I completely agree with you. I think only the femoral head at that point,
Correct.
instead of at that location, they tend to deposit. So more or less the drug spread is in the similar area. One important
and the tendon is going to move.
Correct. Your voice is breaking. Hello, is Madam there?
You are not audible.
Madam, you are not audible. Yeah, Avinash, you have.
Till Madam joins back, I would like to ask one question to Amit. As you do a lot of TCAS with adductor canal block and you place catheters as well. So there was an article published in 2015 which said that early mobilization is possible with adductor canal block. And it was published in Anesthesiology in 2015. And then in 2016, in Anesthesia Analgesia, there was an article which said there is a risk of fall even after adductor canal block. They compared adductor canal block with femoral block. They took some 40 patients, and in the adductor canal block, they used 0.5% ropivacaine along with catheter. And in conclusion, they said that there is a risk of fall even with adductor canal block with continuous infusion. So do you have any thoughts on that?
Yes, that's a really nice question. And one thing I'll share what literature says first, and I'll also share what I do in my own practice. One thing is we have to understand that whenever there is risk of fall, there are causes other than motor paralysis as well. There are multiple causes when patient tends to fall, and most of the time we as anesthetists always blame on the motor blockade and all that. So patient can fall because of multiple reasons. They may be drowsy, they may have tight breaths, they may fall. So there are a big surgical side, patient factors, and so many other factors which are responsible for fall. So that is one thing. Secondly, when we talk of motor sparing block, very rarely those force dynamometric studies where they really assess quantitatively the motor weakness. What I have seen is whenever the adductor canal block is given with volume more than 15 ml, so you have to look at the stretcher of the patient. When the volume is more than 15 ml, it tends to sip up and it becomes more of a femoral triangle block. and again there is chance of motor weakness. Most of the studies have shown that continuous infusion through adductor canal catheter is 0.2% ropivacaine, and then there are issues. Again, the placement of catheter is again a challenge. So I have modified my technique. I may be able to show you one or two slides from my presentation. Maybe I'll just show you here. Yeah. I'll share how to share. Yeah, just a minute. So I'll share. So the catheter placement can be of different ways. You can see here how the catheter is being placed. So it is in plane and the nerve is, out of plane. Here, long axis of nerve and, long axis of probe as well. So if you put it in the long axis of nerve and long axis of probe, that is the best placement. If the catheter is placed, most of the time the adductor canal block is done in the first way. The mentioned, you can see the nerve, and near the saphenous nerve the catheter is placed. The catheter tends to move. It may go cranialward and it may land up with a femoral triangle area. So that can lead to a block which is not expected. So what I tend to do is I apply and utilize this oblique approach. The oblique approach in which we see the femoral artery and the catheter is slowly moved obliquely. I hope I have a video. Yes, I have a video for that. So here the catheter, the probe, like here is our adductor canal, and then I move the probe in such a way that probe lies in the long axis of sartorius, and from craniocaudal I tend to place the catheter. So I move the probe to such an extent that I continue to see the circular artery, and just by the side of artery I put my catheter. So this way it is beneficial. You continue to see the artery and your catheter tip lies. So it lies along the whole length of adductor canal. So inadvertently going into femoral triangle, that can be avoided. Also, I use only 10 ml for adductor canal block proper. I give 5 ml in nerve to vastus medialis area. So total 15 ml. And once the catheter is placed, I continue with an infusion 0.1% ropivacaine at the rate of 5 ml. And what we have found are it stays consistently there, and patients are pain-free even after 24 hours. I hope I have answered your question.
Yeah, excellent. Mamta madam, your presentation was excellent. Rather, I would like to say there is a take-home message that initially when we started with adductor canal block, the usual dictum was to go as distal as possible till the artery becomes posterior and then give the block to avoid nerve to vastus medialis. But now it is not the case. Rather, it is proved that nerve to vastus medialis provides innervation to knee joint. So rather, you should go as proximal as possible. So I think that was real good take home message. So I just wanted to ask a question that along with adductor canal block, if the surgeon infiltrates in the capsule, we call DIA, so is it more beneficial or does it give advantage if the surgeon infiltrates as well as we give adductor canal? Compared to only local infiltration?
Yes, definitely. Lot of studies have been done for the combination of LIA with adductor canal block, and they have shown there is more analgesia and muscle weakness is not there. So definitely it helps.
So I think only LIA doesn't help. If we can give adductor canal as well along with LIA, it would be more beneficial.
Yes.
Can I make a comment?
Yes, madam.
What happens is the effect of LIA actually doesn't last more than 6 to 8 hours. But as we have always said, the side component or the posterior capsule infiltration always retains the effect for longer period. So when you combine LIA, the posterior capsular infiltration with local anesthetic and adductor canal, both the components like the anterior component taken care by adductor canal and the posterior component taken care by the infiltration of the posterior capsule, that becomes a wonderful combination, and the patient remains in excellent condition, maybe up to 24 hours as well, and the opioid requirement just goes down. We generally don't have to give even a single dose of opioid in the first 24 hours, and that is a big achievement, I think, with this technique.
Thank you, ma'am. Ma'am, regarding PENG block, it was an excellent demonstration. We really appreciated your presentation. I just wanted to ask whether this block can be given in patients who are on antiplatelet agents.
Yeah, actually, this is a bit controversial, but it's nice to labels this block as basic block. Okay, this is one thing. Secondly, under ultrasound, when you are seeing the vessels, I think you can definitely give this block to the patients, because these are the patients who need to be prepared or we have to wait for the surgery. So you can definitely go ahead and give this block even in patients with anticoagulants or antiplatelets. And but you should try to reach the correct plane with the correct identification of all the relevant structures and single needle maneuver. I mean, don't keep on pricking the patient and needling here and there. It should be a clean block, and I think nobody has ever said that about this block that you cannot give.
Regarding another thing, madam, Amit also discussed the same point. So in patients with fracture, we do give as a rescue block or on arrival block, because the patient has a fracture, he has pain, and we try to relieve the pain. But patients coming for plasties, for example, hip replacement surgeries. So how does this block help in those patients who are coming for surgery, elective surgeries?
You can give this block in the pre-operative period. I mean, after your spinal, you can put this PENG block, and that will take care of the periarticular pain. And you can just add a lateral femoral cutaneous nerve for the surgical site pain, and that should take care of complete analgesia for your hip arthroplasties. Do I answer your question, Himanshu?
Yes, ma'am.
Yeah.
So there is one question from delegates as what is the composition of LIA mixture and fast track protocol at your institute?
Yes, LIA mixture, we are using combination of sensor cane, normal saline, antibiotic, and morphine and adrenaline. And we are making a solution of 60 ml. And for fast track, we are using adductor canal block. Means within 48 hours, patients are getting discharged after knee surgery. And for them, we are preferring adductor canal block.
Yeah, actually, we are, in our institute, we don't routinely make them walk on the first day. I mean, day 0 of surgery. Our patients are up and walking within 24 hours. The next morning, they start their physiotherapy and they walk on day 1. And basically, for LIA technique, surgeons use two types of solutions. One is the deeper solution, what they say they infiltrate in the deeper planes, and another solution with just 0.25% sensor cane, they infiltrate in the superficial layers before they start closing. And we don't add any steroid to this, because our surgeons are always worried whether it can increase the chances of infection when you put the steroid locally and some tissue reactions also. So we don't add steroid to our LIA.
Ma'am, one more question. If we are giving adductor canal block or LIA, and it is quite possible because it's a procedure, so there is a possibility of failure. So what is the rescue plan? So in such patients, so do we have a rescue plan?
I think if you have done your adductor canal block well, you should not have any failure, because you are putting the drug in front of you, visualizing the femoral artery, visualizing your saphenous nerve, and depositing the drug. Unless you have really made some error and you end up injecting normal saline, your patient should not have any pain. First thing. Secondly, the block dynamics or the kinetics, I should say, isn't it? Every patient will have a different duration of analgesia. So we need to be ready with it's always a part of the multimodal analgesia technique. You must have a paracetamol, you must have a rescue tramadol, or maybe if it is available, fentanyl, whatever you want to add, some opioid. But it is these blocks, or in today's era, I think we can't go only by your regional anesthesia technique. You need to combine all the modalities. That is the protocol for ERAs or early rehabilitation after surgery. So you should always combine a paracetamol, opioid, your regional techniques. Maybe sometimes if the patient has neuropathic pain, you may like to add pregabalin. So you have to combine everything and give the best to the patient.
Thank you.
I have
So
one
much.
question for Dr. Bharti from Dr. Manvikar.
Yes.
Ma'am, have you ever seen foot drop with adductor canal block in your practice?
Actually, foot drop can be seen more often if you practice the distal adductor canal block, where the drug may seep posteriorly into the popliteal fossa and you may block the component of the sciatic nerves. In our institute, we don't do the distal adductor canal block. We do either the mid-thigh or even we go for the proximal adductor canal block, where the chances of foot drop are not there actually. I haven't seen since when we have started doing either the mid adductor canal or the proximal one. But with the distal, yes, there used to be foot drop in so many patients. So that is one of the things you should not be doing when you are worried about the foot movement or you want your patient to be ambulated quickly. So no distal adductor canal block. Always go at least mid-thigh or mid adductor canal or the proximal adductor canal, because it can happen with distal.
Yeah, fairly well, madam.
Anything else?
Dr. Bharti, can I ask?
Yes, of course.
Dr. Bharti, with your 20 years of long-standing experience and expertise in anesthesia for hip and knee replacement surgeries, can you share any interesting case with us?
There are so many interesting cases, because whoever comes to our hospital, I think with a fractured hip or coming for partial hips, they are always interesting cases. You don't know whether you want to operate them or not, whether your patient will be optimized or not. Recently, I think we had a patient who was admitted, who turned out to be admitted with hip fracture, turned out to be a COVID positive, then needed to be shifted to the COVID ward. Sort of settled after 15 days. She was, she still wanted the surgery to be done. So till then she was on Clexane. So we had to Clexane and I think antiplatelets and everything, all sorts of things. So we had to again sort of optimize her for surgery. And that was the period when I gave her, on admission also, I gave her one block. And again, when she came back for surgery, we again started, we gave another dose of PENG block to her. And I think that really gave her confidence to come up for surgery. And she did really well. Otherwise, the patients with hip fractures, they are always worried, especially the elderly patients. They feel that after the hip fractures, it's probably the end of life for them. They won't be able to get out of the bed. So this block really works well, and I have many patients. I feel so good when I give PENG block to these patients. They become pain-free, and next day on the table, they're ready to take my spinal. They're ready to walk the same day in the afternoon, and you feel good, isn't it?
True. I absolutely agree.
Bharti ma'am?
Yes.
Yeah,
Yes,
it was an excellent presentation, ma'am, from both Bharti ma'am and Sadhya ma'am. Ma'am, there's one question for you.
Yes.
Are there any contraindication to this block, PENG block?
I think only contraindication may be patient refusal and maybe infection at the site of where you want to, the groin infection, if it is there, or the fungal, sometimes you may have those fungal infections. So that may be the only contraindication. And of course, the allergy to the local anesthetic if the patient has the history. But apart from that, I don't see any specific contraindication for PENG block. No.
Okay, ma'am. And ma'am, can you elaborate any precautions to be taken while giving this block? Because you mentioned about the ureter.
Yes. Three, four points. First thing, this block should be done under ultrasound. That is my advice.
Right.
Because you need to identify all the critical structures. Though they are far away, they may come in the way of your needle. So should be done under ultrasound. Try to identify all the structures, the muscle, the tendon, the femoral artery, the lateral femoral cutaneous nerve, and femoral nerve, of course. So once you identify the structures, then plan your trajectory so that your needle remains on the lateral side of the psoas tendon. Never try to do any medial to lateral needling for this block, because that is the danger. If you do that, then you have a chance to injure the ureter, I should say, or deposit the drug intramuscularly in the psoas muscle, which can go up to the femoral nerve and cause motor blockade and the quadriceps weakness, which doesn't serve purpose when you are talking about the motor sparing PENG block. So this is the basic care you should. That is why I said when people are trying to formulate some technique by landmark. Yes, it is good if you do have access, which means that you can at least do something, but it doesn't remain safe because the critical structures are there, and this is a deep block, isn't it? So unless you see something, putting the drug blindly without identifying all these critical structures is not right. So these are the precautions you should be taking.
Sure, ma'am. Yeah, thanks a lot. Yeah.
So are there any questions remaining?
Bharti madam, what is your opinion about suprainguinal fascia?
Oh, I love that block. Yes, I mean, in one sentence, I love that block because that does cover everything, but the articular branches sometimes. Because with suprainguinal fascia iliaca block, I think your drug may still reach up to the lumbar plexus, but we don't know whether it reaches at the place where the articular branches are separated from the main nerves. So the other Dr. T.S. Can we combine? That will be then ideal combination where you will take care of all the main nerves as well as the articular branches. That give a complete analgesia. That is my take.
Yes, ma'am. Thank you. Thank you.
Thank you.
Any questions remaining? Hello?
I think we are okay.
Questions are over.
I think it questions are.
Is Mutha sir around? Is he there? Dr. Mutha?
I can't see him.
Yeah. Okay.
I answered his question. He had put some question.
Yeah, he has.
Yeah. Sometimes this morbidly obese patient, he does this genicular nerve block for prehabilitation.
Correct.
Surgery. That area sometimes of course it is more of a people with chronic pain do that more often than but yes, it is one of the modality for prehabilitation in this group of patients.
Yeah, I think genicular nerve blocks he's doing routinely. Yes, but I think it maybe you will have to identify it under the fluoroscopy as well as ultrasound. That is a better approach. Right. Because just landmark technique is now with the ultrasound in your hand is not enough. So you can definitely go and with the ultrasound identify the supromedial genicular nerves actually, and try to block them so that the patient can walk and the pain is taken care of.
Yes, thank you.
Yeah. Any more questions?
I think you can wind up.
Yeah.
Avinash.
So thank you to the speakers and the panelists for sharing their experience. Before concluding today's webinar, I wish to thank our Dr. Parag Sancheti, Medical Director, Sancheti Hospital, Team PRAC, Dr. Ashok Sham, Dr. Nitin Bagli, and Mr. Rahul Chobe for successfully organizing this webinar. Thank you all.
Yeah.
Thank you, everybody.
Still have we stopped streaming live?
Yeah, it's still streaming live.
Excellent.
Thank you.
Thank you, sir.
Thank you, Himanshu. Thank you.
Thank you.
Amit. Thank you very
Amit.
much. Thank you, madam. Thank you very much.
Really appreciate it.
Thank you all.
Thank you, Himanshu.
Thank you,
A big thank you. Network was on and off. Yes,
Mamta.
yes, madam.
Bharti and Mamta.
Thank you.
Thank
Thank
you.
you, thank you.
होत्या स्लाइड्स
Hello.
Mamta मस्त.
Very good presentation.
भारती मॅम, सदर मॅम, खूप छान झालं.
Bharti madam,
हो
Very nice.
बोला.
खूप छान सॉल्व केल्या.
हो ना, चला. Good.
I think we are still live.
Recording is
We are
still on.
still live.
Hello.
Are we still live?
Okay. Thank you.
Thank you.
What to do now? Yeah. We are still live, huh?